So just type something. Let me know that you can hear me. Looking at the text box now. Or you can unmute yourself and join the conversation. That's quite all right, whatever you feel comfortable with this morning. We have just about 5 more minutes before our lecture actually starts. So if you have anything specific that you'd like to ask before we get started, go right ahead. Hey, Jackie.
Hey,
How are you this morning?
I'm well. How are y'all?
I'm all right so far.
Good, good, good. Yeah, I'm trying to be the teacher, be the student. It's a lot of adjusting, but
It is a lot of adjusting, isn't it? I think the hardest thing is probably trying to keep them on a schedule.
yes.
That's probably the hardest thing, trying to make sure everybody gets up like they're actually going to school, keep that set schedule. That's probably the hardest thing.
My 5-year-old is in pre-K and he's still in the bed right now. I'm like, well, what do I do? Do I force him to wake up and then he be whining all morning? I don't know.
Oh yeah, I know. It's kind of hard to do,
Yeah.
but we're gonna have to make it work, aren't we? Well, we don't have much of a choice.
No,
Got to make
ma'am.
it work somehow. That's for sure.
My biggest concern is this EKG chapter. Are we gonna be
Yeah,
testing?
well, it's gonna be a probably simpler, you know, than what you think, because we're not gonna be doing uh, real detailed strip interpretation. It's gonna be very, very basic. I've given
Okay.
you some accesses to or links to some online practice tests that you can take,
Mhm.
and actually there's an online, well, there's a quiz that I have uploaded that you can take and practice, and I'm trying to work on a Blackboard quiz with it as well.
Okay.
Just something that you can use to practice by before you take your test is what I'm looking at.
Okay.
But the strips that you're going to have to identify are very, very basic, very basic. You're not going to have to know heart blocks, and you're not going to have to
Yeah,
know anything.
that's the one that was. I'm like, it's three different ones. Oh my God.
Yeah, you're not going to have to know that. No.
Okay.
If you were working in something like ACLS, or we were doing more advanced stuff, we would do that. But no, no, we're going to keep it really simple.
Okay.
Keep it simple. It's not going to be that difficult. Not difficult to say.
That's good to know. I can breathe a little bit.
You can breathe a little bit. Yeah, absolutely, absolutely. Yep. Take a deep breath.
See
We
more
still
people
have some
coming
people
in.
popping in.
Is atrial fibrillation one of the
Yes.
main dysrhythmia or arrhythmia disorders that we'll focus
Yeah.
on?
Yeah. It is. It is. Yeah. Atrial fib, and that'd be easy. It's easier than what you think, and the strips are
Yeah.
real identifiable. They're not anything tricky. All right. So it's 10 o'clock. We're going to go ahead and get started. We're going to start with chapter 26, and that's caring for clients with cardiac arrhythmias. Just like in your presentation class, you can see that there are some highlighted text here, and these are links that you can select, and they will prompt you to some videos or some additional reading to help you better understand EKGs. So first we're going to look at the EKG recording of a healthy heart. And every EKG is made up of this. You're going to have grid boxes, and you're going to have the actual rhythm. This is the electrical impulse. So the electrical impulse is going to have a P wave, a QRS, ST segment, and your T wave. Then you can have, occasionally, you may have a U wave. A U wave, if you ever see that on an EKG, is lots of times an indicator of potassium. So the potassium level may be skewed, may be off, and so when you see that U wave on your rhythm strip, check the patient's potassium. That's one of the most common things you'll see. So your P wave, we have a P to R interval that starts at the beginning of the P wave to the beginning of the QRS. Each one of these little boxes is 0.04 right here. So what you do is you just count the number of boxes for that interval. So once you count the number of boxes for that interval, you multiply the number that you get by 0.04, and that's the number you get. So here we have 1, 2, 4, and 5. So it would be 5 times 0.04, and that's going to give you 0.20, which is going to be your P to R interval. It's the same thing whenever you're looking at the QRS. It's the same interval, so you're going to count this as well, and then you would multiply it by the 0.04. Now, you don't always have to include the QT interval whenever you're interpreting an EKG strip, but there are some medications, especially your dysrhythmic or antidysrhythmic medications, that may require you to count the QT interval, and you would just document that as need to. So this, remember we talked about the ST segment being elevated for MI, so this is where you would see this right in here. This little slip would be your elevation here for your ST. So remember that your electrolytes most commonly, or that we need for conduction, are what? What are those electrolytes that we need for conduction?
Is it potassium, magnesium,
Yes.
sodium, and chloride?
That's it. You're right. So those are the electrolytes that are essential for conduction. It's going to be potassium, magnesium, sodium, and chloride. Those are essential for conduction of your cardiac. That gives you this electrical impulse. So when you're looking at a rhythm strip, there's aspects that you need to follow to identify these rhythms. So first, we're going to look at the rate. The rate you can identify by the number of P waves that are in a 6-second strip. You count the R waves. And let me pull up that real quick so I can show you what I'm talking about whenever I'm talking about counting the R waves. So you see, in this particular strip, this is 6 seconds. And whenever you identify rhythms for your test, you are going to make the assumption, I'm going to go ahead and tell you, it is going to be a 6-second strip. So all you have to do is count your R waves. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8, 9. Sorry, this is 9. So the heart rate here is 90. So you're going to count, like I say, each one of these. This is your R wave. This is your R wave. So each R wave is what you're going to count. This has 9 in it. 9 times 10, 90. So that's how you're going to get your rate. So the heart rate is 90. So that's what I'm referring to when I say count your R waves. So you count your R waves, multiply by 10. So then you're going to look and see if there's a P wave. So remember, here's your P wave. Each QRS have a P wave. So that's going to be your relationship there. What does a P wave look like? Does each R wave have a P wave in front of it? Then you're going to look at your QRS to see the width of that. And then you look at your P to R, and what is the width of your P to R interval? So you want to make sure that your QRS is between 0.06 and 0.12, and that your P to R interval falls between 0.12 and 0.28. These are considered your normal or your regular values here. And then look and see if your R to R is regular, like here. Are the R to R's regular? Is there the same number of small boxes in between each R wave? That's what you're looking at when you're looking at the regularity. So the first strip that you're going to have to identify will be normal sinus rhythm. The rate of normal sinus rhythm is 60 to 100 beats a minute. And this is just a reference to your normal sinus EKG reference. You can click this one on your PowerPoint and go to the PR interval. So we're going to go through the EKG for the normal sinus rhythm. Sinus Brady will be less than 60 beats per minute. I'm going to pull up some EKG reference when I finish this so we can go through these. But your sinus Brady is going to be less than 60. Some causes of sinus Brady, heart disorders, intracranial pressure, hypothyroidism, digitoxicity. These can cause a slow heart rate. When you have a slow heart rate, that is not sufficient to maintain a cardiac output. So you may check your patient's blood pressure, check their level of consciousness. But know that a healthy heart or a healthy athlete may have a heart rate of less than 60. And that's perfectly normal for that person. So you really have to do a detailed history of your patient to determine if that would be normal for that person or not. Sinus tachycardia. This is sinus rhythm that's 100 to 150 beats per minute. 100 to 150 beats per minute is sinus tachycardia. Causes that exercise, which would be normal. Anxiety, pain, those can cause tachycardia. Fever, hemorrhage, shock, which we've talked about in the past, can cause tachycardia. A PAC, you need to know what it is. You are not going to have to identify PAC on your test, but you do have to know what it is. So causes of PACs, you need to know this. It's caffeine, nicotine, can be some heart disease. Hyperthyroidism can also cause a PAC. SVT. So this is a dysrhythmia of the heart. The beats are greater than 150 beats per minute. Causes of SVT can be hypotension, renal output, chest pain. So with SVT, you can click on this video here. It will take you to giving medication for SVT. And when you give medication for SVT, especially adenosine, you have to make sure that you flush the IV first. You will rapidly push in the adenosine. You'll be looking at the cardiac monitor. The patient's heart will stop. When the patient's heart stops, then they will immediately start back. The patient does feel that. They're very flushed. They can feel like they're going to pass out, that kind of stuff whenever you give them adenosine. But watch the video and you'll be able to see that in that video. Atrial flutter. You are going to have to identify atrial flutter on your test. Classic sawtooth pattern. If you can pick this sawtooth pattern out and you know that atrial flutter, it is classic sawtooth, you'll get that stripper every time. Atrial fibrillation. The atrium quiver rather than contract. As you see here, there's no P wave. This is irregular and no P wave. This is atrial fibrillation. Complication of atrial fib, stroke. That can happen from atrial fib because clots are forming in the atria because it is not contracting, it is fibrillating. So you have the development of clots at that time. So the medical management for atrial fib, chemical cardioversion, you can give medication to hopefully convert the patient if they're in atrial fib. You may have to give some amiodarone. That's one of the medications of choice. We also give heparin when the patient is in atrial fib to help the prevention of further clots. We then follow with Coumadin, and the patient may have to be discharged home on Coumadin. We may have to do an elective cardioversion, which is different from a defibrillation. An elective cardioversion, the patient has to give consent for that. Then they're sedated, and they are given the electric shock. That is your elective cardioversion. If the atrial fib is not responsive to any of these treatments, then you have to do a surgical procedure. So it restores the surgical procedure, helps restore the normal conduction of the heart is what you're hoping to do. Heart blocks. The treatment for a heart block, you need to know the treatment for a heart block is a pacemaker. Third-degree heart block, second-degree heart block type 2, they need a pacemaker. Anytime you have a complete heart block, that patient has to have a pacemaker. These are the different types of heart blocks. Like I say, you are not going to have to identify a heart block on your test, but you do need to know what a heart block is, some of the causes of heart block, and what is the treatment. But you are not going to have to identify a heart block on your test. So those are your atrial dysrhythmias. We're going to talk really quick about ventricular. So your ventricular dysrhythmias, PVC, is a ventricular contraction that occurs independently in the cardiac cycle. It happens before the SA node initiates. Causes or assessment findings for ventricular dysrhythmias: pallor, nervousness, sweating. You're going to feel that fluttering feeling, fluttering feeling. I'm going to say that one more time, fluttering feeling in the chest. Most PVCs are harmless. They're related to anxiety and stress, fatigue, alcohol withdrawal, tobacco. Most of the time your PVCs are not harmless. I'm sorry. Bigeminy, you need to know this definition. Bigeminy is every other beat of a PVC. These are your precursors to lethal rhythms. 6 or more PVCs in a minute. Run bigeminy, like I said, a run bigeminy, that's every other beat is a PVC. 6 or more PVCs in a row can lead to VTAC. When a person has PVCs, lots of times they're given lidocaine IV to help calm those ventricular rhythms. VTAC. So ventricular tachycardia, you are going to have to identify this rhythm on your test. VTAC, the patient can lose consciousness. They can have a pulse, depending on how long the dysrhythmia is present. The longer they remain in VTAC, then the patient becomes pulseless. So once the patient becomes pulseless, then you have to start CPR. So remember, VTAC, these ventricular arrhythmias are a result of MI. Remember, that's the dysrhythmia, the most likely. VFib, you are also going to have to identify this rhythm on your test. It's just like this. The ventricles are fibrillating. There's no pulse with VFib, none at all. The patient is not conscious of VFib and they do not have a pulse. So you have to do immediate defibrillation. You have to get that AE and do immediate defibrillation with VFib. The only way to diagnose a cardiac dysrhythmia is with a rhythm strip or a 12-lead EKG. You cannot identify a dysrhythmia by feeling a patient's pulse. You can feel the irregularity of the pulse, but that is not an identification of the rhythm. You have to have a 12-lead EKG or a rhythm strip. So you cannot just feel a pulse and identify that rhythm. All you feel is the irregularity. Know the difference between an EP study and an echo and an EKG. They are not the same thing. An EP study produces the actual dysrhythmia by stimulating the structure in the conduction pathway. So an EP study they can do to actually see where in the heart the dysrhythmia has taken place. That's what they're going to do with the EP study. They're going to look and see where the conduction is occurring, and at that time they hope to use some radioactive waves and eradicate that tissue that's causing the conduction error. So make sure that you study, look up EP, and know that information about EP study. These are just some drugs that are used to treat antidysrhythmics. Lots of times we give the amiodarone, one of the most popular drugs we give. We give a lot of amiodarone. Know the difference between elective cardioversion and defibrillation. They're not the same thing. Defibrillation is the only treatment for life-threatening ventricular dysrhythmia. So pulseless VTAC and VFib, defibrillation immediately. You
Miss
can
Schumann,
have
you said know the difference between the electrical cardioversion and what?
defibrillation.
Defib. Okay.
Right. Elective cardioversion is when the patient is in a stable rhythm, such as atrial fibrillation, and they sign a consent for that. With defibrillation, that's for pulseless VTAC and VFib, and that's where you use your AED, so the patient would be unconscious. Anytime you do an elective cardioversion or defibrillation, before the jolt of electricity is given, the person who is handling that piece of equipment has to shout all clear.
Right.
No one can be touching the bed during an elective cardioversion or a defibrillation. If you're touching the bed during any one of those procedures, you will get the jolt as well. So they have to stop CPR during a code to give that defibrillation for that cardiac rhythm. Does that make sense?
Yes, ma'am.
Okay. So know that you have the external defibrillator. It's where they put the paddles on or the hands-off pads on the patient's chest. That's an external device. You can have your implanted device. Remember, you can have an internal defibrillator implanted as well, very similar to the pacemaker. And that's those patients with the cardiomyopathy are the ones who are the candidates for that. So a pacemaker insertion you can give to help control the cardiac dysrhythmia. You have demand pacemakers and fixed rate pacemakers. Pacemakers can be permanent or temporary. You may do a temporary pacemaker if you're waiting on some medication to clear the patient's system. Maybe a medication is what's causing the dysrhythmia. So once the patient's body has cleared that medication, that dysrhythmia will resolve on its own, and you can remove that temporary pacemaker. Or sometimes they put in a temporary pacemaker while they're waiting on the pacemaker rep to get into town with a pacemaker. That could be the other thing. Know about radiofrequency catheter ablation. This is used, it's a heated catheter, and that destroys the dysrhythmic tissue that's causing the complication.
How long does a temporary pacemaker usually stay in?
Well, it can stay in maybe 24, 48 hours, especially if they're just waiting on some medication to leave the patient's system. If they're just waiting on that medication to metabolize, it may be 24, 48 hours. It's not very long. And then again, they may a lot depends on if the patient's going to have a permanent pacemaker for some reason. They may have to leave a pacemaker in until the rep gets to the facility with the pacemaker so they can insert it. But it's not very long. A pacemaker rhythm, we're going to have to know what this is. The way on the pacemaker rhythm has a spike before the QRS. It's just that simple. It's a little spike before the QRS. Sometimes you just may only see spikes on the strip. You may just see spikes, and that's because it's just 100% paste and the type of pacemaker it is. So this 100%, this is 100% paste right here. This patient doesn't have any of their own beats in this. This is a link to a surgical procedure for getting a pacemaker. You can just click that on whenever you review your slides. So whenever your patient is having a cardiac dysrhythmia, decreased cardiac output. So decreased cardiac output is what? Low blood pressure, low urine output, changes in level of consciousness. Go back and review what your low cardiac output looks like with your patient. So when they're having dysrhythmias, you may want to get them to rest. They don't need to be up running around the room. Make sure they get some supplemental oxygen because that heart needs a little extra oxygen now. So these are the rhythms that you have to identify on your test. Atrial fib, irregular, no P wave. How do we treat atrial fib? And what is the potential complication from atrial fib? Atrial flutter, sawtooth pattern. If you can pick out the sawtooth pattern, you're going to get atrial flutter every time. VTAC, how is that treated? VTAC, how is that treated? And then VFib is always treated with a fibrillation. Pacemaker, a spike on the rhythm strip. And then these are your normal rhythms. This is their rates. So if you can count and multiply by 10 in that strip that's going to be on your test, then you know these rhythms. It's just that simple.
And you say it's the number of R waves times 10.
Yep, R1 times 10. So this, just to look at this is 90. This is a sinus rhythm right here, sinus rhythm. There's a P wave before every QRS. You have 9 QRS here times 10 is 90. There's a P wave before every one. It's normal in shape. Here's the same thing. Let's see this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. The rate here
140.
is 140. Yes. It's 140. Correct. So that is sinus tach. Sinus tachycardia. This one is 1, 2, 3, 4, 5. So what is that rate?
50.
50. So if you got a heart rate of 50, that's sinus Brady. There's a P wave, right? That's your P wave right there. P wave before every QRS. So that's 50.
So the P wave has to be present for it to be normal?
Yes. Has to be a P wave for it to be normal. The P waves, there has to be a P wave for it to be normal, yes. All normal rhythms have a P wave. So normal sinus rhythm, sinus bradycardia, sinus tachycardia, all those have a P wave.
Miss Schumann?
Yes.
For some reason, I don't see that. I don't have that slide you were just on with the rhythms.
The one that's on now,
Yes, ma'am. Not this particular one. The one we just came off of. That said rhythms.
this one. The one with the sinus rhythm.
I think she's talking about the one that had like the rhythms and then it had like AFib and
Yeah,
irregular
the one you
and no
saying we need
P
to know the
wave.
difference in.
Oh,
I
okay.
just wrote it down.
Let me go back to that real quick then. It takes a second for it to load back up, but let me. Oh, there we go. This one.
Yes, ma'am. That one.
Okay. All right. Sure. Absolutely.
I'm just looking for.
And this one should be on the recorded. The one that the lecture I already had recorded for this. You should have access
Okay.
to this.
So we don't have that actual slide in our
Right.
PowerPoint.
It's not on. Yeah, you don't have the actual slide on your
Oh, okay.
PowerPoint, but it should be on the lecture that I recorded already for this. It should be there.
Okay.
And I'm recording this one as well.
Okay.
So this one will be up on Blackboard as well too.
Okay.
So yeah, yeah. No
All right.
worries, you'll get it.
Thank you.
You're welcome.
I have a quick question.
Yes.
On the A flutter, like I understand that the tachy, the sinus tachy, sinus brady, and then all of those are normal. When it says irregular or regular, what do you mean by that? Because like
Because atrial fib can be either one.
okay, but then the atrial flutter can only be
It's usually regular.
okay.
Well, so no, right here, atrial fib is
Mhm.
always irregular.
Okay.
Atrial fib is always irregular. Atrial flutter can be regular or irregular. So
Okay.
that's okay. If you can pick out the sawtooth pattern, that's all you need to know.
Okay.
If you can pick out the sawtooth pattern, that's all you need to know. See, this is a sawtooth pattern right here. So this is your atrial flutter. This is a heart rate of 80, and this is atrial flutter. Does everyone see that? So this is your flutter. And then here, this is your atrial fib. It's irregular. There's no P wave anywhere in front of this QRS. So this is your atrial fib pattern. I think I have this posted on Blackboard. If not, I will go back and post this for you guys. This is VTAC, and this is VFib. Sometimes with VTAC, they can have a pulse, but lots of times it's pulseless. The longer they stay in this rhythm, the greater chance they have of losing their pulse. And then here, there's no rhythm here at all. Nothing. There's no beat. This is total fibrillation. So this is VFib. And this is asystole. A flat line, straight line, asystole is what this is. There's no electrical pulse anywhere. No electrical current.
Is there one that's more dangerous than others? Like if there's patients, like if we have, two patients with two different ones, is there one that's priority over others?
Sure, whenever you have that patient who starts to have any type of ventricular dysrhythmia, that's the patient that's going to need your attention. So if they start having some occasional PVCs, or if they are going into atrial fib, so anytime your patient has a normal rhythm and they start displaying any type of irregular rhythm, whether it's atrial fib or PVCs, then that's the patient that needs your attention. Because then you need to look at some underlying causes for that rhythm. And start with your lab work first. Does that make sense?
Yeah, I just didn't know. I was curious to see if one was like higher than others.
Yeah, they are. Your ventricular, your VTAC, most definitely. So when you start having that patient start having PVCs, whether it's one PVC or they have bigeminy, they start having some PVCs, you need to look at that patient because they can develop a lethal rhythm quickly if you don't look at those underlying causes. And then atrial fib, if left untreated, can result in stroke because they can develop clots. So you really have to get that rhythm under control to decrease that patient's risk of developing a stroke from the clots that could possibly be forming. Any questions about ventricular rhythms? Any more questions about ventricular rhythms?
Earlier, you said that we would have to know the difference between the EP study, the echo, and what was the third one?
EKG, because that's all in one question. I'll just go ahead and tell you. That's in one question.
Okay. Is
So
it
you
gonna
need to know what does what.
be like matching one like
No, it's not a matching one.
okay.
No, it's not a matching question. It's not a matching question. But it does ask you about a diagnostic test. So that's why you need to know what an EP study is and what it's for, because it is going to ask you about a diagnostic test. And most people are probably going to pick the echo. The echo is not the answer. Because it's all how you read the question. Any more questions about cardiac dysrhythmias? I have plenty of practice on Blackboard for that. I have some websites where you can go to and actually identify and practice those rhythms. But just focus on the ones that are going to be on your test. Don't try to interpret second degree heart block times 2 or PACs, PVCs, PJCs, any time of aberrancy like that. No, that's not on your test. Sinus rhythm on your test, sinus Brady, sinus tach, AFib, A flutter, V-tach, and pacemaker. That's it. Those are the ones that if you're tested on NCLEX, those are the most common ones you would be tested on NCLEX. They're not going to ask you for heart block interpretation on an NCLEX. How to treat one, yes, with a pacemaker. That's your answer. How to treat a pacemaker, yep, that's it. But to interpret it, no. Okay, so we'll talk about heart failure. So the slides are divided up into left-sided, right-sided heart failure, and pulmonary edema. Your book lumps left-sided and right-sided heart failure together. I've separated it. Your book lumps it all together.
Are we doing chapter 27 or 28?
Should be chapter 26 and chapter 27. I'm sorry.
27 is for hypertension.
Okay. I'm sorry, I put up the wrong slide. Thank you for correcting me. I put up the wrong slide. Hypertension.
I was about to be like, uh-oh, I ain't look over there.
Well, me too. Hypertension. Yep, that's it. I'll get it right in a second. Siri, you got a question?
Well, no, Jackie answered it. Or
Okay.
you answered it.
Okay, yeah. I just had the wrong thing up. My bad. I'm trying to learn how to use things too. Still not giving me the right one. Share files. I want hypertension. Yep. I just pulled up the wrong slides by accident. Forgive me, this is all new to me too. All right, so hypertension. So this is just a link to a video with guidelines for hypertension. When you look at the guidelines, you read guidelines in your book, and in your ATI book, you'll see that guidelines kind of differ from publisher to publisher. But just know the guidelines that are in your book for testing purposes. So you need to know the definition of blood pressure. Blood pressure is the force produced by the volume of blood in the arterial walls. Blood pressure reflects the ability of arteries to stretch and fill with blood. Also, the efficiency of the heart as a pump and the volume of circulating blood. That's what blood pressure is. Blood pressure is affected by age, which is not modifiable, body size, diet, activity, emotions, pain, position, time of day, gender, and some diseases. Make sure that you always have the correct size cuff when you're taking your patient's blood pressure. The wrong size fitting cuff can give you a blood pressure that's not correct. Blood pressure increases with age, and there are some chronic diseases such as diabetes and renal dysfunction that play a part in blood pressure. Mechanisms that regulate the blood pressure: arterial baroreceptors, regulation of the body fluid, renin-angiotensin-aldosterone system, which is related to your renal functions, and vascular autoregulations. So your systolic BP is determined by the force of the blood from the left ventricle as it ejects during systole. Patients may have an elevated systolic blood pressure as a result of arteriosclerosis. The arteriosclerosis causes the vasoconstriction because it's that occlusion that causes that constriction that increases the blood pressure. Your diastole is the arterial pressure during muscular relaxation. If the arterioles are constricted, the blood under pressure is greater. That causes the higher diastolic blood pressure. I'm not asking you any questions about the CASP. There are questions about this on the test. Hypertension, for those of you who like a visual, hypertension is a silent killer. Oftentimes there are no signs or symptoms the patient is experiencing, nothing that triggers that they have high blood pressure. The size of the heart muscle increases, that leads to heart failure. Myocardial ischemia can also have an impact on hypertensive hemorrhage of tiny vessels in the eyes. When you see that, that's usually an early stage. Cardiac failure, a stroke, renal failure. These all are some causes or some signs and symptoms that the patient may be having, and they might not even know that they have high blood pressure, but they may have some of these signs and symptoms. Hypertensive heart disease is elevated blood pressure that causes a cardiac abnormality. You have to know these stages of blood pressure. You have to know pre-hypertension is 120 to 139 and the diastolic is 80 to 89. You have to know stage 1 and stage 2. So you have to know these stages for your test. Categories, you have to know the categories for your test as well. You have essential hypertension, which is a primary hypertension, or it can be idiopathic, which means it has no known cause. 95% of the cases sustained elevated blood pressure with no known cause. So 95% of your essential hypertension is idiopathic in nature. Secondary hypertension is elevated blood pressure result from secondary cause such as renal disease. So if someone has renal disease, they're in renal failure, or they're on some medication, they could have secondary hypertension. One single elevated blood pressure does not confirm hypertension. You have to do some consecutive blood pressure readings before that diagnosis is made. So you would send the patient home, have them record their blood pressure every day, twice a day at the same time, have them bring that in a couple of weeks later, sit down with the patient, and determine whether or not you are going to diagnose that patient with hypertension based on those readings. White coat hypertension is elevated during evaluation by a medical professional, and that could be a nurse, a nursing assistant, a doctor. They walk in to take the patient's blood pressure, and it's going to be elevated every time. But if you send them home and let them do a log, have them log that blood pressure a couple of times a day, you may find out that they really don't have hypertension, and it's just because they go to the doctor, and that's the only reason why it's high.
I hear that a lot.
Huh? You hear that a lot?
Mm-hmm.
Yep. But one single blood pressure check that's elevated does not mean that patient is hypertensive.
So with the essential hypertension, it's just you're saying it just is you don't really know why they have it, and then with the secondary, it's because they have another underlying issue.
Right, an underlying issue, yes.
Okay.
Yep. So here are some of your causes of your essential. Like I said, 95% of your cases are unknown. But then it could be age related, because as you age, you have a tendency for your blood pressure to be increased. That's just an aging factor. Can be a family history. So it could be just genetics that's making your blood pressure high. And African Americans tend to have a higher blood pressure. Risk.
Too much salt.
Too much salt. There you go. That'll do it, won't it? Here are your risk factors for hypertension. And as you see, most of these are modifiable, right? So many of these are, some of them are not, but a lot of them, for the most part, are very modifiable risk for your essential hypertension. Your secondary hypertension, like I said, your causes can be any primary condition that affects the renal function. Could be that as well. So it could be like a secondary cause. And here are your risk factors for secondary hypertension. So you see it can be related to some medication. So if you take birth control pills, that's a secondary cause. That can be a cause for a secondary hypertension because you're taking birth control. Brain tumors, pregnancy. So these are conditions that can cause this secondary hypertension. Use of steroids, machines.
So if someone was on birth control, or like someone had a brain tumor and they either stopped taking the birth control or the brain tumor was removed, would the blood pressure go back down to where it was supposed to be?
More than likely, yes. Once you correct the underlying cause, it can correct the blood pressure, yes. So your assessment findings for someone who comes in with high blood pressure, headache, dizziness, fatigue, insomnia, nervousness, nosebleeds. I've seen a lot of nosebleeds from hypertension, a lot. Flushing, fainting, nocturia, retinal and visual disturbances. That's where you're going to have the little blood vessels in the eyes would be busted. You have that rupture of those little blood vessels in the eyes. You need to know these assessment findings. They are going to be on your test. This is going to be on your test. It's a given. It is a select all other apply. I can't make that any easier. That is select all other apply. Not once, but twice. So how are we going to diagnose your hypertension? Well, we need to see if there's any underlying causes, right? Before we jump off and say someone definitely has hypertension, let's look and see if there's any underlying causes first. So we want to look at a good overview of the heart. We can do EKGs, echoes, looking for large ventricles, mega scans. Might have to do some angiography, ophthalmic testing, renal testing, blood test. Look at that BUN and creatinine. See if it's renal related. What's causing that to be high? Do some diagnostic tests first. This is in your book. I don't know exactly what page it's on, but I do know that this is in your book for diet and that kind of thing. So whenever you're looking at diagnosing someone with high blood pressure, you want to get them to do lifestyle modifications first before you put them on medication. Get them to change their diet, lower their sodium, exercise, moderate consumption of alcohol. They need to stop smoking, reduce their caffeine, do all of these lifestyle modifications first before you put them on blood pressure medicine. Because if people,
With,
what's
I'm
that?
sorry, is that with just the pre-hypertensive one or all of them?
Well, if a well, for all of them really, but if the patient is pre-hypertensive, if they are in that category, most definitely they need to take these steps. But someone who is already diagnosed with high blood pressure, if they make these changes, they can probably reduce some of the medication that they're taking. So if the patient loses weight, if they stop smoking, if they decrease their sodium, if they limit their alcohol, if they do all those modifiable changes, they can reduce or eliminate the need for the blood pressure medication. Because if they stop smoking, that decreases their heart rate. That just helps so much. It just helps decrease that blood pressure if they just take that time to modify those risk factors. But if someone in the pre-hypertensive stage did all those things, they may not ever need high blood pressure medicine. If they're stage 1 or stage 2, they may decrease the amount of blood pressure medication that they're on. And in some cases, eliminate some of it. But they have to do the modifiables. But if it's genetics, sometimes you can just you may not be able to eliminate all of the blood pressure medication. You still may have to take some, but maybe not as many. So the drug therapy depends on the stage that the patient has been diagnosed with the hypertension. So the most common medication that a patient is started on first, one of the first medications is going to be your thiazides, your HCTZ, your hydrochlorothiazide. That's going to be one of the first medications that a patient is started on when they are diagnosed with hypertension, because it's very mild, it's a very low dose medication, and it's easily tolerated. So as far as your nursing management, when you're teaching someone with high blood pressure, you want to take their blood pressure sitting down, their legs are not crossed. You can compare the blood pressure in both arms. You can take lying, sitting, and standing blood pressures and compare those as well. Question the patient about are they following their medications? Are they not their medications? Do a cardiac assessment, include a family history, and what's their current symptoms at the time. Remember, we can start with non-pharmacological methods first for lowering that blood pressure. So you're going to modify the diet, weight loss, stop smoking, all those things. Try those before you start them on medication. And then, like I said, the first medication you may start them on is going to be the hydrochlorothiazide. This DASH diet will help stop the hypertension. That's a low sodium diet, low fat, low cholesterol. If you look in your ATI diet nutrition book, you may find some information about the DASH diet there that you can look at. Teach the patient to take that medication even when the blood pressure is normal. Some people feel that once they get their blood pressure under control with medication, they can just stop taking it. That's not true. You have to take that medication regardless if it's normal or not. You have to take it every day. And here's a link to a video on the DASH diet as well if you want some more information about that. When you're teaching a patient about taking a new blood pressure medication, make sure you let them know about some possible side effects they may have, such as dizziness. So tell them that they need to stand up slowly, and that will help decrease those occurrences of postural hypotension or orthostatic hypotension. They need to stand up slowly. So you need to know the difference between accelerated and malignant hypertension. Accelerated, that's a markedly elevated BP. And then your malignant is untreated accelerated hypertension. So the patient's been walking around with this accelerated hypertension, and they come into the emergency room and they have this. It's dangerously elevated blood pressure. So for those undiagnosed hypertension, they either knew they had high blood pressure and just chose not to take their medication, and it just progressed until it got to the malignant stage. And at that point, it's fatal. It can be. The kidneys, brain, and heart may be permanently damaged by malignant hypertension. Arterial blood vessels may rupture. You'll have those retinal hemorrhages that can lead to blindness. Stroke can occur. If there's an aneurysm anywhere, that's a possibility that it could burst and cause hemorrhage and shock. The patient can also develop pulmonary edema and MI, and they can go at renal failure as a result of untreated malignant hypertension. Accelerated, and then it becomes malignant, and if it's left untreated, they are going to have some issues. And once you get this malignant hypertension under control, you can hope that they've not suffered any of these consequences. So that person who comes in with malignant hypertension, the goal is to lower the blood pressure within 1 to 2 hours if they have malignant hypertension. We're going to give them some IV medication, help bring it down. If it's less critical, if the patient's within a situation where they can take oral medications, you're going to give them oral. You're going to give this person some oxygen if they are in malignant hypertension crisis. So you're going to either give them IV medication, PO medication, and you're definitely going to give them oxygen. Whenever you are treating this malignant hypertension, you have to monitor that patient's blood pressure frequently. You have to monitor that blood pressure at least every 15 minutes, if not more, on the medication you're given, to make sure that it's being that the medication is being effective. So you have to make sure that you're monitoring this patient closely as you're trying to decrease that blood pressure in a safe way. Hypertensive emergency, you need to know this. There's a video link here to that. So with a hypertensive emergency, you're going to give them medication. You're going to monitor that blood pressure frequently. Keep emergency equipment and drugs at the bedside because this patient may go into cardiac arrest when you have a hypertensive emergency. So you have to make sure you have everything together and ready for that patient. Any questions about hypertension?
For the test, is there one chapter that is like more heavy on information?
No,
Okay.
they are equal. They are equal. So for the test, You need to know how to reduce the risk for hypertension. What are those risk factors? You're going to need to know about monitoring the patient after you give them blood pressure medications to bring it down. How often should you monitor that pressure? You know, at least every 15 minutes, right? You need to know your stages of hypertension.
When you said we need to know to monitor them every 15 minutes, you mean we have to monitor their blood pressure every 15 minutes, correct?
Yes.
And at what point do you stop monitoring every 15 minutes?
Well, until the patient's blood pressure is within range of what the doctor has prescribed.
Okay.
Because I'm talking about someone in a hypertensive crisis, like their blood pressure is 210 over 105. So you're going to monitor that patient until they get down to at least 150 systolically. And that may take 2 or 3 hours to get it there. So risk reduction. Know your stages of hypertension. Um, Pre-hypertension. A heart healthy diet. So how do we treat atrial fib after the patient has, say if it's controlled atrial fib, they may be on dysrhythmic. And they may be on antidysrhythmic medications. They may have some Coumadin. What's
How
another
many
name? Coumadin.
how many
Warfare.
questions are on the quiz?
Warfarin?
Yeah, warfarin.
Miss
Uh,
Schumann,
yes,
how many questions is it going to be? Is it going to be 50 again?
it's going to be 42 questions for right now. 42
Okay.
questions. It's going to be roughly 42 to 45 minutes. Make sure you can identify a fib, a flutter. Make sure you can identify atrial fib, atrial flutter, V-tach, V-fib, sinus rhythm, sinus tach, and a pacemaker. What does the SA node do?
That's the pacemaker of the heart.
Correct. Elective cardioversion versus defibrillation. EP studies.
You say EP study?
Yep. I'm typing it in over there on the chat. Can you see it?
Yes, ma'am.
I'm trying to type and talk at the same time. I'm not very coordinated. Purpose of radio frequency ablation. Purpose of the radio frequency ablation. What is that purpose for that? Anybody know?
Like reroute the conduction of the heart by like
Thanks.
zapping off the tissue,
Yes,
affected
it does.
tissue.
Exactly. That's exactly what it is. Exactly what it is. Yes.
You said burning it or?
Yeah, that's what it does. Yep. It eradicates that tissue that's causing that conduction issue in that place. Yep. There's a little bit more that goes to that, so make sure that you kind of delve into that a little bit. And how do arrhythmias affect the heart? Anybody have any idea how arrhythmias affect the heart?
Wouldn't there be like a decrease in cardiac output because the heart can't fully contract?
Absolutely, that's it. It affects the heart's ability to pump. Yep, so you have a decrease in cardiac output. What's the role of the autonomic nervous system in the heart? So an echocardiogram primarily looks at the structure and function of the heart, right? What is the first regulatory?
Hydrochlorothiazide.
Yep, that's it. Um, So make sure that whenever you are studying for your test, that you are trying to get to a level 8 on Prep U. I know that most people who did really well on this test got to level 8 on Prep U, because I went back and looked, and everyone who did well on the test did a level 8 on their Prep U. Make sure that you are looking, or if you're doing concept maps, continue to do that. I did put a information sheet on Blackboard about test taking tips. I would look at those test taking tips, and I would implement those test taking tips whenever I did Prep U. Start doing that when you're doing Prep U, because if you wait and do that during the time of the exam, you're going to run out of time. And so the exams are timed so that to preserve the integrity of the test and to prevent any type of cheating that can occur. Because if you're cheating on these exams, you're not going to pass NCLEX. That's just a given. That's already known. So we have to preserve the test to be able to pass NCLEX. So that's why it's training. and we want you to be able to do well because we want you to be able to pass NCLEX. So you don't have time for it to be like an open book test. So make sure that you are looking at have all of your prep you done before the test, and look at your ATI book as well. And if you look in your ATI diet nutrition book, there's information about heart healthy diets. There's a cardiac chapter in there as well. They're short in the ATI diet nutrition book. They're very short. Are there any questions about hypertension or cardiac dysrhythmias?
That last one that you posted about using an automatic blood pressure, I couldn't catch it.
So as an automatic blood pressure machine, I'm sorry, an
Okay.
automatic blood pressure cuff, especially if you're given IV blood pressure medication, it needs to be on an automatic mode. You're not going to take that manually. You'll use a Dynamap for that.
Okay.
Ms. Schumann, will the test be open just Wednesday or how it was for the last test?
It'll be open the way it was for the last test. It'll be open.
Okay.
It'll open up at that mid
Okay.
and then close. It'll be like, what, 48 hours almost to take it.
And is the prep you going to be due that Monday night again?
Yes.
Or like, okay.
Let's do the day before the test opens.
Okay.
Just like it always has been. Yeah. Prep you is always due the day before it opens.
Are you gonna send us another Kahoot?
Yeah, if I can find one, I will. And usually that closes the day before the test opens as well. But I'm going to try to find one that I can send about that as well. Send another Kahoot. And you should have lots of practice for EKGs on Blackboard. A lot of links on there to help you with that.
So you said that the prep U is due on Monday. So the tests are technically Tuesday, but our calendars you guys gave us say tests are on Wednesday. So is it the test technically Tuesday and not Wednesday?
The test opens on Tuesday at 12:01 a.m. That's
Okay.
when the test opens. Tuesday at 12:01 a.m. Prep U has to be done before then, yes. That Monday before, it has to be done. Just like it was before we went on break. Prep U is always.
No, and that's what I'm saying. Like I understand that. So our tests technically are on Tuesday though, not Wednesday, because the calendars you guys gave us said tests were on Wednesday.
That's when it closes.
Okay.
It closes on Wednesday. So just make sure that, the test opens at 12:01 Tuesday and closes on Wednesday at 11:59. Prep U has to be done before the test opens.
I don't know what I just did.
Huh?
I was just clicking on things.
Oh, somebody had a question. You can raise your hand. I'll try to see it, but before I can see, nobody has a question. If you got a
That's what I just
question,
clicked on, but I didn't mean to.
raising your hand, yeah. Does anybody have any questions?
Miss Schumann,
Yes.
How long will it take for you to be able to upload this recorded lecture to the Blackboard?
It usually takes 10 or 15 minutes for it to populate before to let me upload it. So I don't know exactly how long it would take this one because it's longer than the ones that I have already on there that's recorded. But as soon as it's available, I'll send you maybe a remind message or a Teams message and let you know that it's up. Is that okay?
Yes, ma'am. That's perfect. Thank you.
You're welcome. Yeah, it doesn't take long. It doesn't take long.
Thank you for doing this, Miss Schumann.
You're welcome. I plan to do this again next week, and it'll be kind of the same setup. So
Yes, thank you.
make sure that you review the information before you come to the course, so that you'll have questions ready for me. Because it's easier if you know the information before we start. That way you can look through it and then let me know if you've got anything specific. Okay? And always feel free to send me a message or email me, especially if you're having difficulty with a topic, something that's not quite clicking with you, let me know. And I can try to explain that to you, okay? In some way. We can either meet back on here or however and talk about it.
Okay.
So if you got any questions, you guys just let me know, all right?
Thank you.
You're welcome. So that's good. Anybody got anything else? Sierra, you got anything?
Do you recommend or do you know another place other than PrepU that we can have practice questions? Like I was told something about the Saunders. I don't know, Saunders something for practice questions.
Well, if you have access to a Saunders review, that's good. I don't think that's a website though. That's usually like a book. You have to purchase a whole book for that. NCLEX review.
Okay.
Yeah. But most of your PrepU and your ATI are probably your best sources right now for that. A lot of it is just you have to study this every day. You truly have to pick up this stuff, and you have to study it every day. Whether it's an hour or 2 hours, you really have to study this every day. This is something you're not going to be able to study, a couple of days and think it's going to be adequate enough. It just really is not. This requires that you actually study every day. Anything else, guys? Alrighty. Well, we're going to call it into it. You guys have been great. Let me know if there's any way I can help you, and I will get this uploaded as soon as possible. Y'all have a good day, all right?
You too.